Hello and welcome again to Cardiac Imaging Agora. On this session, this morning will identify a Gerber T defect in a patient with endocarditis. Joining me this morning is one of our, again, superstar fellows. He's actually today or tomorrow is his last day of cardiac fellowship, and he's moving on to become an advanced EP fellow. Dev Patel is a good friend, a wonderful fellow, wonderful colleague, and above all, a great Barcelona fan. He overcame his birthrights as an American and got to enjoy a lot of European soccer or football. Dev, good morning, and let's start with the case.
Thank you for having me. So this is a 44-year-old male who we saw while doing TEs, but it's an interesting case. He has a history of hypertension, paroxysmal atrial fibrillation. He had a bicuspid aortic valve and had previously had endocarditis and type A dissection. He underwent a mechanical valve replacement with the St. Jude mechanical composite Bentall procedure in 2016. He's had recent stroke, polysubstance abuse, and he's transferred from another facility for surgical evaluation of infective endocarditis. They had positive blood cultures there that they treated, but they thought there was something suspicious for endocarditis, so they transferred him to Cleveland Clinic.
So Dev, this is his EKG on presentation.
Yeah, so you can see here, it's normal sinus rhythm. The things we look for when we're evaluating patients with endocarditis is we see a lot of patients with aortic root abscesses, and they develop because of where the AV node is located. A lot of them develop pre-R prolongation, and some of them we get concerned about heart block. So as you can see here, you have a patient with normal sinus rhythm. The PR interval looks normal. But the P wave looks a little bigger, so maybe he has some left atrial enlargement. The other things to note is his heart rate is a little faster than you'd expect. It's probably, looking at this, 100 beats per minute. He has an incomplete right bundle, but nothing else. So this is a patient who you haven't seen the manifestations of complete heart block or prolonged PR yet.
This is a very important point. So this is not, again, a static issue. So on these patients, as you will know, we start with an EKG at baseline. We put them on telemetry. And very often, actually, we have EKGs repeated multiple times during the day. Any sign of PR prolongation is a sign of progression and involvement of the conduction system. This is not, again, a static issue. This is something we need to monitor during the hospitalization and not just one-off with an EKG. So we will go on. We get a chest X-ray. Here's the chest X-ray.
Yeah, so you can see here it's a frontal chest X-ray. You can see his prior sternotomy wires that the patient has had prior open heart surgery. You can see what looks like a trachea here.
He's intubated.
Yeah. So, and then the other things to note is he has pulmonary edema here bilaterally and an enlarged cardiac borders. So probably he has heart failure and then some mild pleural effusions at the bottom of both the left and right side.
So as usual, again, this is a guy with suspected endocarditis, prior valve surgery. We go on to get a surface echocardiogram. Here's your surface echocardiogram, parasternal.
Yeah, so here's parasternal long axis. Things to note right away is you see the RV is dilated and the septum is actually moving towards the LV. So probably you have some signs of RV volume and pressure overload. There's a PA catheter that you can see in the right ventricle. You can see his aortic valve, but you don't get a good idea of how much regurgitation there is. And if there's concern for endocarditis, you don't get a great picture here. There's very minimal mitral regurgitation that you can see here.
Also the pleural effusions, if you notice.
Yeah, exactly. So you can see a pleural effusion here beyond the LV.
Good. So this is his RV inflow.
So as you can see from the RV inflow, the right atrium and RV are dilated, and there's a lot of tricuspid regurgitation here. So probably I'd call this severe tricuspid regurgitation looking at the color Doppler.
Again, as you suspected, the right atrium is dilated, significant tricuspid regurgitation. And so far, the only mechanical complication we're seeing, if this a true endocarditis, is probably a tricuspid regurgitation. But beyond that, we don't see much on the surface echo.
So here's a short axis view of what looks like the aortic valve. You appear to see a mild or some thickening of the aortic valve, but you don't get an appreciation. So this is suspicious. If you saw this on a surface echo, this is suspicious for endocarditis, but not truly confirmatory. If you're looking for mobile vegetations, you don't get a good idea because of shadowing from the metallic St. Jude aortic valve.
So as you know, a couple of things we're looking at here. If, as you said, if there is a vegetation protruding through this mechanical valve, through the metal here, we will see it. The other thing is we're looking at the aortic root here and trying to see if there is an abscess. Again, very tough images. You have to strain your eyes to see something here at about 9, 10 o'clock, but this could be a tricuspid valve structure. It's just hard to see. And again, we look for shunting anywhere here, or a defect at the level of the aortic root, and really it's very hard to define anything here on these limited images. So here are some apical views.
So here apically, you can see that the RV is sort of enlarged, the right atrium's enlarged, it's sort of pushing into the LV. This is what truly we call RV volume and pressure overload. You again see that tricuspid regurgitation, but you don't get a good idea, even on these views, confirmatory of endocarditis currently.
Yeah, the only thing that's concerning for me is this area here in the 4-chamber or 5-chamber view, where you can see some thickening between the mitral, aortomitral curtain right here, all around this area. But again, it's just not clear to the point where you can say this is definite endocarditis. But there is some thickening there. This can be sometimes very difficult to ascertain whether it's endocarditis or not, especially early post-op. These are areas where you can have edema and things like that. But again, it's just nothing clear here. And again, you can see the significant regurgitation on the right-hand side of the screen. Some more images of the right side.
Yeah, again, you see that tricuspid regurgitation on subcostal view. And maybe there's some flow acceleration, but this is tough.
Yeah, and the subcostal view. The reason we do this, and in these patients, actually, personally, I favor starting with these views. If you're suspecting any left to right shunting at the level of the septum, anywhere in the septum, interventricular intraatrial septum, this is a good view to start with, because you're right perpendicular to the probe. Or parallel to the wave, to the ultrasound wave. So this is usually a good view. But here, given the severity of the tricuspid regurgitation, I think it's very hard to, as you said, to see if there is anything there.
Yeah.
So with that in mind, what do we do next?
Yeah, so there are two things we consider in patients with endocarditis. One is you could get a endocarditis CT, which we're doing more and more as we realize there are risks of transesophageal echocardiogram. But here, given the metallic valve and to get better images, I think we'd go forward with the transesophageal echo. But I was wondering, Dr. Gerber, if you could just spend 30 seconds explaining your decision process of getting a CT versus transesophageal echocardiogram.
So the mainstay remains right now for endocarditis, at least worldwide and in the US, is a surface echo and accelerating it with the next step, which is a transphageal echo. There are a couple of things, actually. We had a whole session with Dr. Paul Kremer in this series on the use of CT in endocarditis. We, as you said, have been using CT more and more in these patients. The beautiful thing about 4D CT in these patients is, first, it gives you better anatomic definitions. It visualizes the aortic root all the way up. So you can see that that structure there. So it's sometimes these are views that are limited by transphageal echo, and it's hard to see. Some of the metallic issues, shadowing, it's the same, applies to all technologies we use in these patients, whether it's MRI, whether it's echo, whether it's CT. Again, we're becoming more and more, I would say, liberal in using our CT in these patients. Of course, in patients who are intubated, patients who are critically ill, this is a limitation, and that's why we chose TEE here in this instance, because the patient was intubated, critically ill in the intensive care unit, and it's hard to move these patients around to get a full CT. Of course, renal function plays also a role here. If this patient had compromised renal function, these CTs need to be done with contrast. That's another factor. Again, it's an almost like an accelerating stepwise thinking, where you start with a surface echo, with the EKG actually, then a surface echo, then a TEE. Often with patients with mechanical valves or bioprosthetic valves or any valve replacement or even pacemakers, I think a transphageal echo is essential. You should never stop at a surface echo, and that's supported by the guidelines.
Yeah, I agree. So that's what we did. We got a transesophageal echo. So you can see here, this is mid-esophageal aortic valve long axis. You can see here this huge thickening around the aorta, or specifically at the aortic valve, going all the way into that aortomitral curtain. You can see the thickening around the prior Bentel procedure as well. So this is consistent with a large aortic root abscess. And then here, you don't get a good appreciation whether there's AI. There's not significant AI here.
Yeah, you can see that disconnect between where the aortic valve suture line is right here and the mitral valve, and that's where the abscess basically takes hold right at the, as you said, at the aortomitral curtain, and tracks all the way up posteriorly. So for those of you who don't do TEE, this is posterior because the probe right now is in the esophagus, looking at the valve from behind. So this is all posterior, tracking all the way up. That's something, you know, again, this is disadvantageous for transthoracic echo because posterior structures are not well seen, and hence our inability to see it earlier. So here's another view of it.
And so this is the advantage of biplane, where you just take a cross-sectional image of this abscess, and you can see on the right that associated with the abscess, there's mobile vegetations sticking from that posterior aortic root abscess. And then you get, again, an appreciation here of that there could be some kind of Gerber T defect going from that aortomitral curtain into what appears to be the right atrium. And I think that one of the things Dr. Gerber, the first day they taught me in the echo lab, was you have to remember that the tricuspid valve is more apically displaced than the mitral valve, and which is why you get this, you can sometimes get this, what we call a Gerber T defect, and a shunt between the LV and the right atrium, as opposed to getting a RV to left atrium shunt.
Again, this is, if you mentioned this, illustrate this beautifully. This is the beautiful thing about using biplanar or even multiplanar views with modern TEE, where you can see in one plane here, you don't see any connection between the LVOT and the right side, but when you put another plane at 135 and you cross it at 13 or almost at 0, you can see that flow coming from the LVOT into the RA. And that is clear now why we couldn't appreciate it, because of the severity of tricuspid regurgitation here. And by 2D without color, you can see even visually that defect itself on the far right images here, a defect right from the left ventricular outflow tract, where you can see also some shaggy vegetation here into the right atrium. So here again, our attempt at getting a 3D image of that defect, where you can see it right here, like on the left-hand side, you can see visually a defect connecting the LVOT into the right atrium, and again tracked here by color. And one thing is, if you can see here, the extent of that abscess, it starts at about 9 o'clock and it tracks all the way up to about 3, even 4 o'clock posteriorly, all around. So this is a huge, huge abscess around this mechanical valve. Again, beautifully illustrated by transthoracic echo, and not seen very well with transthoracic echocardiography. And you can see almost the base of the heart almost falling apart here, right? You know, everything is infected, right? At the crux of the heart, between the tricuspid valve, the mitral valve, the aortic valve, intra-atrial septum up on top. And here by 3D color, you can see the flow entering the right atrium. Any questions on those, Dev?
No, these are great images, a good case.
Yeah. So this is important. You got those images, so thank you so much. But it's important also not to just focus on one area, to make sure you interrogate the color all around the aortic valve, because sometimes the defect can enter into the pulmonary artery here. It can enter into the RVOT. It can enter into the RV. So this is not a congenital defect. This is a defect that's acquired, and it can it depends what the infection tracks and affects more where it goes. Let's track this. So now, Deb, this is your favorite organ, the atrial appendage. You're going to spend next 2 years of your life putting things in it.
You can see the appendage, but you can get a better appreciation of that large abscess.
You can see how far posteriorly and laterally it tracks. You see that? With a lot of, cavities in it, abscess cavity, pus, some mobile echo densities.
Embolization as well,
And that explains his cerebrovascular event, all these small emboli.
So here we get our appreciation. Dr. Gerber is really good at teaching transgastric and going deeper even with the transesophageal view. So here you can see the tricuspid valve better, and you can see that defect even better. So I think it's important, even if you don't see great defect on mid-esophageal, to go deeper into transgastric.
Yeah, this is a good view in my mind, just trying to go transesophageal to transgastric. I do it very often, as you will know, for illustration, to see there's coronary sinus coming right here, the mitral valve and short axis, which is rare to see by transesophageal echo unless you do 3D. And again, you can see that defect tracking from the LVOT with a punch hole here into the right atrium, right where the coronary sinus comes.
And you get that nice color right at where the defect is.
So this is a Doppler, continuous Doppler of that defect to ascertain where it's coming from. And you can see this is a systolic flow over 4 meters per second. Again, huge unrestricted shunt from the left to the right side. So just, every time we go over this, people start complaining that this is not a true Garbodi. Actually, fortunately, I came across this recently. So Garbodi can be direct defect type 2, which is the LV to RA, and that's what we have here. And these are often acquired prior surgery, supravalvular, and then you have the direct defect, the indirect defect, which is the type 1. And these are usually left ventricle through the septal tricuspid valve leaflet into the RA. And these are usually, as you can see here from the illustration, the direct, the acquired, infected, mechanical ones. Track straight from the LVOT into the RA, versus the other ones, the congenital one, go from the LVOT through the tricuspid valve leaflet, interventricular septum, tricuspid valve leaflet into the RA. So actually you have 2 punch holes, one into the interventricular septum, and then one into the, and this is a zoomed up view of that to illustrate that. So you can call it Garbodi still, even if it's acquired, thankfully. So we don't get criticized about that. So this is a series from our institution here by Tom Wang, one of our advanced fellows, and Bo Ju, one of our attendings, with many of my colleagues on this report. This is talking about a few dozen patients who presented to our center with Garbodi defect in the past few years. And you can see here just the 30-day mortality, at least at our center, was 8%. But there is a big difference between patients treated conservatively here, 58% mortality survival. And if they intervened on with surgery, of course, it's up to 83%. Of course, there is some selection bias here, but this is at least has been our approach, is to aggressively intervene on those patients, especially in this case where there's a young individual, and hopefully give them a better outcome, because the short-term outcome is bad, but the intermediate long outcome, maybe at 1 year, will be catastrophic for these patients. So these are some of the take-home messages we go over every time when we present these cases, is to recognize the mechanical complications of endocarditis, follow the anatomic markers and track the flow. Don't be satisfied with just a surface echo. Use CT, again, a beautiful presentation by Paul Kramer on this series on the role of CT with endocarditis, especially if you're planning for surgery. CT is phenomenal. Subxiphoid views by surface echo and transesophageal imaging with transgastric imaging is needed. And then you can integrate all these findings into a meaningful report. Any questions about this case?
No, to wrap it up, unfortunately, as Dr. Gerber mentioned, conservative patients don't do well. This patient was not deemed to be a surgical candidate, given ongoing issues with drug abuse. And so the patient passed away, unfortunately, with the abscess. So truly, if the patient is a surgical candidate, as soon as you recognize it, they should go for surgery. The other thing I'll note is one of the first ways that we do a lot of PA catheters in our intensive care unit. And one of the first things to look for when you're doing a PA catheter, especially in a patient with heart failure and maybe endocarditis, is to get saturations of oxygen at each level, because you may be able to say, hey, why is even if the patient has florid heart failure and they may be in shock, why is the PA saturation high? So it's important to get oxygen saturation at the level of the SVC, IVC, RA, RV, and then PA.
Absolutely. This is how often most of these critically ill patients are found, actually, by when you put the Swan-Ganz catheter and you do a saturation run, you can see that huge step up in the RA in this instance, or the RV, it depends on the level of the shunting. And that should be a trigger for, even if you don't see it again by surface echo, a trigger for going for more advanced imaging to illustrate the finding. So Div, thank you so much. I know you have to run. Wonderful morning, and thank you, and good luck with your future adventures.
Thank you. Appreciate it.
Bye-bye.